Hello, good afternoon, everybody, and welcome. Before we get started, a little bit of housekeeping. Please refrain from recording any audio or video or taking screenshots during today's webinar. This presentation and the corresponding slides are copyrighted by Robson Forensic and may not be recorded, copied, distributed, or otherwise used without authorization. If you have any questions as we go through the presentation, there is a Q&A button, or there should be a Q&A button at the bottom of your screen. You can submit questions that way. I think there's a Q&A button. I'll make sure there is. Otherwise, you can submit them to us by email at inquiries@robsonforensic.com. There we go. And we will get back to you either offline or here at the end of the webinar. Today's presentation is by Dr. Joe Muniak. He will be speaking about home care investigations, and this is a growing topic in our casework and maybe in yours too, and that's why you're here. So I will hand it over to Dr. Joe.
Great. And thank you for that introduction. So thank you for everyone for logging on and joining today. I look forward to speaking to you about this topic. I have talk about myself a little bit, just so you understand my background and what I'm here for. So currently, I'm active in the home care industry. I serve as an administrator, a trainer, a care planner for a home care company. I have in the past also served as the director of therapy services, sort of hold those dual roles currently as well. I have quite a bit of background related to hospitals and all levels of care, as far as acute care, inpatient rehab, LTACs, assisted living, skilled nursing facilities, but most recently home care, and that is my active practice at the moment. I managed and oversaw a pretty large interdisciplinary team for the University of Pennsylvania Health System in Philadelphia. I also still serve as an adjunct professor for the College of Rehab Sciences at Thomas Jefferson University in Philadelphia. And a lot of what I teach in my coursework does carry over to some of what we're going to talk about as far as the actions and standards of the home care folks that are taking care of people. So to start out, Anne mentioned this briefly, but home care is a very growing field. These home care attendants is actually the largest growing job in America and projected to be for the next 5 years or so. A lot of this is because folks want to age in place. So they want to stay in their own homes. We've got the baby boomers kind of coming up, and there really just isn't enough facilities for everyone. And plus, people want to stay in their own home. So we're going to talk today about what some of this care looks like, who's providing that care, and what some of those incidents might involve. Um, there are a lot of differences between home care and what happens within hospital or medical settings. The the standards are different, and what you're expecting of those caregivers are often different. To put it simply, when they're in facilities, we oftentimes have rules that they need to follow and things that we do where they're depending on the agreement and the care plan, which we'll spend a lot of time on today, can vary in the amount of supervision assistance provided as long as that's agreed upon between two parties. So, just to wet your whistle a little bit, some of the things that we see, and if you're seeing this in your casework, whether that be plaintiff side or defense, I do both sides of the aisle there, and it really is close to a 50-50 split at the moment. But some of the incidents tend to be around falls. Falls are a pretty obvious and common one. That's with or without an assisted device, can be during transfers. That's usually when it occurs. Incidents within the bathroom, so falls involving the tub, transfers on and off the toilet, things related to bathroom assistance. The locations and the actions of the caregivers are also things we're looking at. Elopement situations, and then assistance with mobility within the community. This one's growing quite a bit. We have a lot of these care companies that are providing assistance in the community. You know, the goals are to get out of the home or to help the person ambulate in the community. And you'd be surprised. We have a few cases that involving supervision or assistance out there, sometimes involving vehicles, that sort of thing. Some other areas we see are feeding. That has to do with food consistency, the size of that, the food aspiration, possibilities, those sort of things. And then occasionally abuse, from the caregiver. So to give a little background, really a lot of what we're going to be looking at here is the care plan. But before I talk about that, you see it in this first bullet here. The in-home care services are often, and this is kind of the federal language, is provided either by skilled or non-skilled. Don't love the term non-skilled. I think, that could be taken the wrong way. But what we're really looking at is, are we talking about kind of medical care that's being provided by the home care company or employees, or are we talking quote unquote about this non-skilled, which really means non-medical in this situation? So an easy way to think of that distinction is a lot of these companies might have a nurse involved with the care or therapists like myself, or CNAs in some cases. The non-medical tends to revolve around the personal support within the home. And there's definitely lines there in which it's guided either federally and by the state in some cases of what they can and cannot do or should be providing. So usually this non-skilled work revolves around a couple main areas, the main ones being mobility or mobility assistance within the home, and then activities of daily living. So ADLs or activities of daily living are bathing, dressing, grooming, toileting, feeding, those areas. Now, the third bucket, usually provided by the non-skilled individuals, would be light housekeeping, meal prep, those sort of things. A big distinction here would be medications, for example. So the non-skilled individuals can provide medication reminders, but they cannot administer in any way, shape, or form. And it's really very clear in some states, a little clearer than others. Some just lean on the federal regulations. But for example, the caregiver for non-skilled might be allowed to open the pill bottle, but in no way, shape, or form could take out a pill or put it in their hand, that sort of thing. Or an alarm might go off and they're allowed to tell them, Mr. Jones, it's time for your medicine, but that's the extent at which they can go. So the services, as I mentioned, are usually focused around ADLs, safety, sometimes companionship as well. I'm very uniquely positioned to speak to this. So when you think about even the therapy world and you talk about physical therapy, speech therapy, and occupational therapy, I'm an occupational therapist. Our role and what we kind of own as professionals are ADLs. It's foundational to our work and myself as a professional. It has a lot to do with what I teach at the academic level, and then also what we're going to talk about here today. So the other piece that I can bring to the table is I serve currently as an administrator and a trainer and somebody that helps provide this education, training, and insight and care plans for a non-skilled service company. So I'm quite literally training the non-skilled, quote unquote, yeah, home caregivers on what their actions should be, how they should be helping with mobility, how they should be helping with these ADLs, all of those bathroom issues we mentioned, safety, and those sort of things, what that training looks like. So I'm developing, implementing, and then overseeing much of that through checks and through creating the care plans and creating the care plan updates. So we mentioned this briefly, but activities of daily living is the bathing, the dressing, the toileting. You need to remember that involved in all of these ADLs is usually a functional mobility component, right? It's the idea of walking to the bathroom or walking to the toilet. How is that done? What does that look like? What should the guidance be? How should they be assisted and at what level? And then how should they be guarded? Those sort of things. So oftentimes that's a lot of what the casework needs to involve or look into is kind of how that guarding was being provided, what was listed in the care plan, and what was the agreement around the ADLs and the functional mobility within the home. That's a lot of the cases that we're kind of seeing here. There's a lot of nuances to that. Oftentimes, as I mentioned, we're talking about caring for individuals in the home. So a little less control than you would in an institutional setting. That can be anything from clutter, from looking ahead to making sure paths are clear, to dealing with more emergent issues, those sort of things. Because as you could imagine, really, oftentimes this is a one-on-one situation. You have this home caregiver with the client in the home, and it's just the two of them. So there's a lot of things to consider there. So the care plans. Much of this comes down to what is established between the families, the client themselves, if they're cognitively able to make these decisions, and the caregiver company. So those care plans should and often do spell out kind of what level of assistance is being provided. So that can, on the surface, very much be the physical assistance that might be provided for mobility. That needs to be looked into on a very individual basis. As I mentioned, this is a very fast-growing field, and we're seeing a lot of changes at the state and federal level on kind of what these rules and regulations look like. There's originally, maybe if you go back 2, 3 years, only really 9 states to 10 states had regulations that they kind of individually produced, and then many of the other ones just lean on what the federal guidelines might be for this level of care. That's always changing. You might go back even from when you come with a case and an inquiry. It might be a certain time period that the event occurred. And then within the last 3 months of when we're investigating it, there could be some new rules or things that have been implemented. So we really want to kind of look at that when we're doing these investigations. A big part of that, as I mentioned, though, is this is an agreement with what services are going to be provided between the caregiver agency and then who's receiving that. That is definitely a two-way street. We need to keep up with that as a caregiver company and then as the providers with the family's input as to how the person's doing. So some examples of that might be, and this is a pretty obvious one, if a home care company is caring for someone and they did have a stroke, or they had a fall, not with the home care company, where they had to have a hip replacement. They have a short hospital stay or rehab stay. They're coming back to the home and we're resuming services. There may be some aspects of that. Obviously, a reassessment needs to take place, and then you want to look at what kind of assistance level they have. So those things might have changed. Also, state by state, and then sometimes just guided by the federal regulations, are how often you want to reassess what's occurring in the home with the caregiver and with the client themselves. Sometimes that can look like, usually, in most cases, it's about every 3 months. Those things want to be relooked at and those sort of things. But that communication tool, the communication back and forth between the family with the needs or the client with the company is important. We're caring for folks that are older and older, and oftentimes have chronic health conditions. So these things can change, and they can change acutely. So sometimes you want to make sure that if there is a change in what that level of assistance looks like, it's well communicated. Also, along that realm of communication, we want to look at what kind of tools or what the agency's using to make sure that the frontline staff are aware of what the needs are of the client. Unfortunately, a lot of these incidents tend to occur when the agency has to send some sort of fill-in or not the typical person who is extremely familiar with the person. So there should be a mechanism of how that care plan is communicated. The new caregiver that's stepping into the home has resources to get hold of the home care company to have things clarified if needed, and that the appropriate trainings taken place ahead of time before that person comes into the home. Most people are very particular about who is in their home and they like the person to be consistent. But of course, as we know, there's sick children and illnesses and other reasons that they might not be able to come. We just got through a pretty wicked winter. We had a lot of incidents where the weather actually dictated who could make it and who couldn't, and for what shifts and that sort of thing. So throughout investigations, these are all things that we want to look at and consider when we're trying to piece things together as to what is occurring. So a few more granular examples of what these investigations might involve. We mentioned the establishment of the care plan. So what is in there? What does it contain? This is something we're going to look at closely. Usually, like I said, it's an agreed upon piece in the beginning when at the start of care, but can also be involved with the reassessment and as the timeline moves forward. What level of family involvement during the initial and the ongoing care plan? As I mentioned, is extremely important. And what's again the ongoing communication from the home care company and throughout the home care company. So those are other things we're going to want to take a close look at when investigating these sort of cases. Was the care provided meeting in the care plan meeting the needs? Okay. So also this has to do a little bit with what are the job duties of the person providing the care, right? So there's usually a gamut of things you can kind of select and choose from of what's being provided, but we want to look at the job duties being carried out by that caregiver and make sure it matches up with what was established in the care plan. Another example here could be the level of assistance. So in some scenarios, some cases, some states actually have regulations on if it's non-skilled providers, there might be a certain level of assistance that if it goes beyond that, they should be looking for a different level of care. So the example there might be what we call in the industry moderate assistance, so mod assist. So that's pretty much where 50% of the effort's being given by the client and 50% by the caregiver. If it goes beyond that, and we're talking about mobility issues, then dependent on where we're looking at the case in the scenario, that might be a scenario that we have to look at a different level of care. Now, that being said, the other side of that coin is we do have these quote unquote non-skilled, non-medical caregivers providing care to folks who might be bedbound, for example. So in those scenarios, you might be using a assisted device like a mechanical patient lift, oftentimes called a Hoyer lift, in order to do the turning of the client for toileting and hygiene and continence issues, and then also to possibly just to even transfer the individual out of bed into the wheelchair. So as you could imagine, that kind of falls under more of the dependent umbrella. And those are still things that a non-skilled, non-medical home caregiver can provide. And again, you want to look at the training specific to that. That obviously is kind of a different level of assistance. You want to make sure they have that training. But then also just to understand that's a scenario that they can provide. And as long as it's spelled out in the care plan and the training's there, that can occur. The home care agency itself, I've fielded some of these questions lately. Kind of from a licensure standpoint, what does that look like? So again, that would be defined by what level of services and what's being provided within the care plan. So there can be a mix, is what I'm getting at. So there might be a scenario where there is skilled services. There might be an RN or a nurse coming in an hour a day or 3 hours a week, but somebody might be receiving 24-hour care and the remainder of that time could be provided by a quote unquote non-skilled, non-medical caregiver. So those things need to be considered as well. And then I mentioned this, but it's worth mentioning again, the educational onboarding practice requirements for the home care employer and with the employee. And that I am directly involved in and provide myself. Okay, another area that sometimes we want to look into and questions have arisen is what is the licensure under which the home care agency is operating? So you just want to take a look at this. Many of the home care agencies do provide both services, both skilled and non-skilled or medical and non-medical. So really kind of you look at those things in combination in relation to the incident and how they match up or if there's a responsibility on one end or the other. Oftentimes, too, you might run into a scenario where people more and more often are receiving care through multiple agencies. So there might be an agency responsible for and involving themselves in the medical side of things and another agency providing the non-medical care. So taking a look at the incident, the guidance, the situation and the particulars around it are going to be very important. So we would want to take a peek at that as well. So just in closing, as I mentioned, it's a growing field and it's challenging in that you have these folks kind of getting sicker and sicker in the home, being cared for by individuals that sometimes don't have a very large breadth of medical background, if any. They quite literally are not able to take blood pressures, things of that nature. So you have these folks kind of getting older and they're on a bit of an island sometimes, right? As we mentioned, they might be the caregiver in the home and they're providing relief to the family. So the family might not even be present as they're caring for the client, as opposed to a facility, right? Where you have a team available and that sort of thing. But there definitely are supports and we would want to take each situation individually and that's how our analyzation and investigations into these matters go. So I know that was a very 30,000-foot view explanation, but I'm open for any questions or anyone that has anything.
Thank you, Joe. We do already have a few questions that came in. Again,
Okay.
if you haven't already submitted a question, the Q&A button is at the bottom. Um, kind of this segues neatly from what you just said, this one. Can you expand on the difference between receiving care in an assisted living facility versus home care in terms of the regulations that apply?
Oh, wow. Great question. I actually had to speak to an attorney about this earlier today. So if it's under this the nursing home or a skilled, let's start with skilled nursing facilities, SNFs, as many of us know them. They are definitely going to have more hospital-based type regulations that we'll be operating under. And if an incident like this were to happen with supplementary help being brought in from a quote unquote non-skilled agency, that would be something we would have to very much look at. But there are differences then, again, dependent on what the contract is for, let's say, assisted living and whether that is independent living, memory care, what's being provided there. Those facilities will tend to have a little bit of different regulations. We obviously, as a team at Robson, do a ton of those type of cases. Just a quick commercial plug, but we have a lot of individuals that we are all full-time employees of Robson, but we cover the gamut from physical, occupational, nursing, nursing home administrators, wound care, nurse practitioners. We have all of that available within Robson. So we can obviously handle those type of cases. I think a little bit more specifically what we're talking about here that we're seeing on the rise is the cases that are happening in the home. And they are less regulated, as I mentioned in the beginning, and those regulations are changing. I think states and the government, federal, is trying to keep up with these changes and make sure they're still providing quality care to folks and that they have their rights met. But yes, there would be definitely some differences between those settings versus what we're kind of diving into here, which is the non-skilled, the non-medical care that's being provided in the home.
Okay. Next one. Is there a point when the home care company recognizes that an individual needs a higher level of care than what the home care company is able to provide? So I guess
That's
like what you were saying with like they can't
yeah.
dispense the medication, stuff like that.
That's another fantastic question. Fantastic question, because I think that is the root of oftentimes some what our investigations were finding is so yes, there definitely is a point and a responsibility on both ends to identify and communicate changing needs, especially for these folks that are kind of getting older or when you've been with the person for a long time. I think everybody can kind of relate to this. It's like anything, if you've been around it every day for several years, sometimes it's hard for you to see the change versus if you go and see a loved one. Let's say you're like me and don't see your mother as much as you should, but you stop in and you see her 8 months later or 6 months later out of versus the last time you saw her, you're going to recognize changes a lot more than that person that is seeing them every day. So to know that and to recognize that that's a bit of the challenge when you have these caregivers that are with them every day. So you look for that. There is a role in what the responsibilities are by the agency, as we talked about in reassessment and check-ins, and to look for that. And there is some responsibility on the caregiver's part to identify and report back changes in function or need. And oftentimes these are cognitive, unfortunately, right? Dementia is a real thing. If you're seeing a real decline or you're seeing an increase in wandering, or they would ask for assistance before and let you know when they were getting up, and now you're noticing that's not always happening. Things of that nature, yes, you would want to report. But as I mentioned, it is a bit of a two-way street because also relying on the family or the loved ones that are with them and usually signing for or providing the care to also report back and be transparent in these changes. There are times where we've had to say, yes, like this is beyond our level of care to provide to someone. And you mentioned a very good example, pretty concrete, the medications. We've had a few scenarios where people might have had a changed medical condition or things like Parkinson's have progressed a bit. The medications have grossly increased, and just the reminders are not enough anymore. And you have to kind of realize as a company, this is where our abilities end from a standards point, and then also what's best for the client. So therefore, you would need to communicate with some other agency or another level of care within that same agency that can provide that. And that definitely is a real world example that has occurred, came up a couple weeks ago. With a client we had, and we actually were in communication with one of the other agencies that were providing the medical piece of this, the nurses and things. And we worked with them and obviously provide information on what's needed, but there needed to be a fresh look at that, either who was providing that assistance or what tools we were using. There's some really amazing tools out there for medications when it comes to distribution and times and what can happen there. But it was tough for the family to understand why we were not necessarily they saw it as us pulling back or not giving care, and we were able to kind of explain that if under this non-skilled services, these people that are providing the home care, they really from a regulation standpoint can't do that. And we explained it to the family that you really don't want them doing that. They're not trained for that. You don't want errors occurring or accidents occurring related to the meds. Obviously that could be dangerous. So yes, there's a lot of communication that goes there, and responsibility. I just don't want to say on one party, but the changing presentation of the individual is extremely important.
So maybe this will be the last question because we're coming to the end. This piggybacks off of that. Who then determines when you reassess the plan of care, especially if someone's been receiving home care for a longer period of time? Like who ultimately is the person that does that, if there is one
Yeah.
person?
No, that's a great question. So that we would just, it depends on what state you're in, but we would look at that. And I'll start there just because sometimes most states will just lean on what the federal guidance is for something like that for this level of in-home care. Usually, I think I mentioned this, usually it's about every 3 months. Now, or any sort of change in status or reported change in status. The individual that's providing that reassessment can be a couple different areas. I myself can do it with my background in history. With non-skilled services, you can actually, an administrator who's trained by somebody like myself can occasionally do it. Some companies choose to have RNs. Some companies choose not to, and even somebody as skilled as myself, they wouldn't have involved. But those regulations are pretty clear. It has to be somebody that really has a baseline knowledge of what they're looking for throughout this assessment. And that could be proven in a few different ways. Their role within the company, their amount of time in this line of work is another example. There's usually a few that would quote unquote qualify someone to make those reassessments.
That's fair. I love an answer that starts with "it depends."
It all depends.
It always depends. Okay, well, I think that's all we have time for today. Thank you, everyone, for coming. If you have any follow-up questions, our contact info is on the screen. Dr. Joe's email is on the screen. If you have an inquiry, you can submit an inquiry through our web form and we can run a conflict check first before we set up a call. We're not hard people to reach, so contact us however is easiest for you. And we hope to see you on the next webinar.
Great.
Thank
Thanks, Ann.
you.
Thank you, everyone.
Yep, bye.